med school. I'm Dr. Andrews. The last time we have discussed division of anemia morphologically into microcytic, macrocytic, and normocytic. And we have said something about the reticulocyte count. Depending upon the reticulocyte count, we can divide the anemias into hypoproliferative and hyperproliferative anemias. Hyperproliferative means most often it is hemolysis or excessive blood loss is occurring and the bone marrow is overproducing. So let us recap. So MCV, depending upon the MCV, divide the anemia into microcytic, normocytic, and macrocytic. Depending upon the reticulocyte, you divide into hyperproliferative and hypoproliferative. Hyperproliferative occurs when there is hemolysis. This indirectly, most often it is hemolysis. Or excessive blood loss is occurring. Excessive blood loss leads on to overproduction from the bone marrow, and that can lead on to increase in the reticulocyte count. Hope this is clear to you. Now, what is the target retic count that you will take? One is the corrected reticulocyte count. What is in the correction? Corrected reticulocyte count, you are correcting for the hematocrit. So let the patient's reticulocyte count is 6. That is, it is 6%. Percentage of reticulocyte is 6%. What you will do is you multiply with the patient's hemoglobin. Let it be 10 grams. And in such case, you divide with the normal hemoglobin. So take it as 15. Instead of the hemoglobin, you can take the hematocrit of the patient, and the normal hematocrit usually taken as 45. This is how you find out the corrected reticulocyte count. A response more than 2 can be taken as the bone marrow is responding. Another method is finding out the reticulocyte production index. Here we are giving some allowance for the early release of the reticulocytes into from the bone marrow to the peripheral blood. So what is being done? You divide the corrected reticulocyte count with a maturation factor. This maturation factor roughly can be considered as, if the hematocrit is between 25 to 35, the correction factor can be taken as 1.5. More than 35, you take it as 1. Less than 25, you take 2. Less than 15, you take as 3. So this is how you identify the reticulocyte production index. If it is more than 3, that means there is a hypercellular bone marrow. Bone marrow is trying to produce large quantity of reticulocyte. If it is less than 2, we can consider that the bone marrow's response is not adequate. So this is how you divide the anemia depending upon or you identify hypoproliferative and hyperproliferative anemias depending upon the reticulocyte count. Now let us think a patient has got anemia and the retic count. So you calculate the retic count bar reticulocyte production index. If the retic count is less than 2, you take it as hypoproliferative. If it is more than 3, you take it as hyperproliferative. Two important conditions for hyperproliferation are: one is hemolysis. hemolysis, and second is blood loss. So how will you identify this? If we check the bilirubin, if the bilirubin is high, indirect bilirubin is high, it means it is hemolysis. The bilirubin is normal, it means more likely to be. And also you can take the history. What is the history, whether there is a history of blood loss is there. So this is how you look into the patient depending upon the reticulocyte count. If the retic count is high, you go for serum bilirubin. And clinical examination also important. Now it's when there is, you identify that there is hemolysis. When there is hemolysis is identified, there are other methods also for tests are there, but here just by looking into the retic count and MCV are going, you go for the Coombs test. That is so when the Coombs test is positive, it means it's an extra corpuscular, that is it is outside the RBC the problem. So it is immunoglobulin is the problem, and the classical condition is the autoimmune hemolytic anemia. So in hemolytic autoimmune hemolytic anemia, there will be anemia. Second, there will be hemolysis indicated by jaundice and other factors. The reticulocyte count and the corrected reticulocyte count will be increased, and you will get a Coombs test positive. If the Coombs test is negative, is most likely due to corpuscular, that is RBC problems, like a membrane defect, spectrin spherocytosis, or elliptocytosis, etc. Or it may be due to hemoglobin, that is thalassemia, or it may be due to enzymes, example G6PD deficiency. So Coombs test will be negative in these conditions, that is intracorpuscular problems. Then again extracorpuscular can also occur. Suppose that what is called microangiopathy hemolytic anemia in malignant hypertension, accelerated hypertension, sepsis, etc. There can be, or DIC, you can get a microangiopathy hemolytic anemia, or when there are artificial heart valves are there, again you can get. So when the Coombs test is negative and there is hemolysis, you think about extravascular, not extravascular, extracorpuscular and corpuscular problems. The corpuscular problem, it can be membrane, hemoglobin, enzymopathies, and most of these have got some hereditary or congenital, and family history will be consistent. So today we have discussed about the usefulness of reticulocyte in identifying the hypercellular or hyperproliferative anemias. Now go for the, suppose the retic count is low reticulocyte count. What does it mean? It means that the bone marrow is not responding properly. So first thing you will consider the nutritional problems. That is, the bone marrow is not getting adequate materials for production of hemoglobin. For example, iron-deficiency, or the bone marrow is suppressed. For example, toxins, drugs, which can act on the bone marrow, suppress the bone marrow. And very important condition is the aplastic anemia. So how will you differentiate between these two, or whether it is due to aplastic anemia or not? The best thing is you go for the total count and platelet count. If the total count and platelet counts are decreased, that means it is a bone marrow, primary bone marrow suppression is going on. And sometimes, very rarely, some congenital conditions like pure red cell aplasia, the count can be normal, TCDC can be normal, platelet can be normal, but the RBCs alone are decreased. Hope this point is clear to you. That is, in pure red cell aplasia, the RBC count alone is decreased with reduced reti count. Platelet count and WBC count will be normal. The total count can be increased, platelet can be increased in other conditions. For example, in infection, TC can be increased. For somebody with iron-deficiency, again platelets can be increased, but this can be diagnosed by not by looking into the count alone. It will be looking at the peripheral smear, looking at the MCV, etc. So today we have discussed 2 points. One, hyperproliferative anemia, hypoproliferative anemia, and how can you diagnose it by looking into the additional findings. That is, one by the Coombs test, second is a serum bilirubin, third is looking at the total count. Hope it was useful to you.